what is the true expectation at year 1 versus year 2?
Yeah, I think that a big part of return to sport is knowing if the athlete is ready.
Yeah.
If they say they're not ready, they're not ready. Even if they pass every single test.
Yeah.
If they don't pass the questionnaire, which is like an IKDC,
Yeah.
if they don't pass that questionnaire and their confidence level is low in their knee,
Sure.
we're not clearing them.
Yeah.
Because that is a huge component.
Sure.
They have to pass the eye test and they have to pass their own test of themselves being ready.
Sure.
Now, if they say I'm ready at 6 months and they don't pass their test, that doesn't work that
doesn't
way.
matter. Yeah. Welcome back, everybody, to the BIOS KOL Sessions. I'm privileged here to talk with a good friend and colleague, Taylor Sloat. Thank you for being here, bud.
Of course, man. Thanks for having me.
Today, we're going to be chatting about ACL rehab and really kind of the art and science of it, because I think, you have to really merge both of those things. Yep. We're going to go over a little bit of prehab, if you've had an ACL surgery, what to do before surgery, kind of the immediate post-op period, the progression. We'll talk about return to play, also some prevention strategies, and then we have some fun questions lined up for the end. Taylor obviously he's a doctor of physical therapy, has a ton of experience as an athlete himself, injuries he's had. He's actually my physical therapist, so there you have it if I'm biased at all. But welcome. Give us a little bit of your background and just kind of how you got into physical therapy. I know you're passionate about football, but how did you get into this kind of subspecialty of ACL, and just, let us know.
Yeah, sure. So I think I have a similar story to a lot of the physical therapists out there in that I sustained a lot of injuries through high school and college, ended up having a couple of surgeries, and those surgeries led me to working with some physical therapists who I thought were highly skilled. And through those experiences with those physical therapists, I kind of switched my major and, tried to pursue that because I wanted to be just like them.
Sure.
So I had a really positive experience both with an athletic trainer and a physical therapist as I was going through some surgical rehab, and that kind of solidified my idea of where I wanted to go professionally. And so in high school, I went to a small school and played a lot of sports, just like anybody does in a small school, and finally kind of settled on football for college. And that was my freshman year of college is when I had my first surgery, and started working with a PT there.
Awesome. Yeah, I had kind of similarly, I had my own injuries, which I really think led to saying, okay, for better or for worse, I always make the excuse like, oh, if I had better treatment, I would have made it to the pros, which is all BS. But you still look back and say, hey, there were things that, that could have been done better. Yep. And that, I think, led me to become a sports medicine doc, and specifically 2002, I don't know if you remember, Willis McGahee dislocated his knee in the national championship game against Ohio State, which I still think we got robbed, but that's a story for another day. And I remember later reading in the newspaper, when there was a newspaper back then, Dr. John Uribe from Miami, fixed his knee, and it was a multi-ligament surgery. And then he came back and actually got drafted by the Buffalo Bills, and that was super inspiring.
Yep.
Where I reached out to them, and thankfully Dr. Uribe let me come to his clinic, and that's kind of how I got started with sports. So it's interesting how being an athlete and our experiences lead us to kind of where we want to go.
Right.
And at the time, those injuries seem so, they're such low blows for us as athletes, but then they also give you this direction in life,
Yep.
But anyways, enough about life philosophy. Today we're going to focus on the acute ACL tear. We're going to talk about more specifically a complete tear, ligamentous instability that needs surgical intervention, just to kind of tone it down, because there's a lot of different ACL tears, but this is what we're really going to focus in. All right, so you just had the injury, you got the MRI, it's confirmed it's torn. You're going to have surgery, in 2 to 3 weeks. What's the prehab look like for you, that initial consult? What are we looking for in the patient, and kind of how do you walk them through that part?
Yeah, so anytime there's an ACL injury or any big ligament injury, the joint often swells. And so priority number one is always, let's get that swelling down.
Sure.
And in order to do that, you've got to offload, and you have to stop, obviously playing the sport or the thing that resulted in the injury.
Yeah.
And you're going to have to calm the joint down to get it nice and quiet so that you can use your muscles properly. we know that when there is fluid present in a joint, your ability to contract your muscle goes down.
Sure.
And so if we are trying to use our muscles before the surgery to try to prevent atrophy, then we have to get the joint to calm down. So that's always priority number one. And then after we get that joint swelling down and kind of in the process, we're working on getting that quad restored and getting it firing properly, and then also restoring some range of motion. If there's also a meniscus injury at the same time, getting back that range of motion is going to be a little tough before surgery. But if it's just a clean ACL, then you can get back pretty close to full range of motion before the surgery occurs.
And how soon after the original injury, should someone start prehab? And then should we delay the surgery to get enough prehab in? What are your thoughts on that?
Yeah, so a couple different philosophies on that. In my mind, that's up to the surgeon, the patient, and the provider that they're working with. But I think that the best thing for a surgeon to hear is that that joint has no swelling or minimal swelling.
Sure.
Because they don't want to operate when there's a mess going on inside of the joint.
Right.
And so if we can get that done and then we can get the quad firing really well before the surgery, then that patient's in a good place. For some people that takes a couple of months, and for some people they get it done within a week and a half, 2 weeks.
Gotcha.
So it really depends on if that person swells a lot, how they're responding pain-wise, and what their quad activation looks like.
And in your, obviously it would be nice to have a baseline before the injury, right? In terms of strength, range of motion, but most people, they've already had the injury by the first consult. So is it still important to get a baseline of like the circumference of the quad? Are you able to still check strength measurements, or is that difficult because obviously they had a bad injury and they can barely move?
Yeah, great question. So if you're kind of a Division I athlete or a professional athlete, you're probably going to have access to some testing data that you took, pre-season or off-season.
Yeah.
And so they're going to know what your jump profile looks like. They're going to know how strong your quads and your hamstrings are. But if you're a high school athlete, or maybe even a little bit younger, or maybe you're done with athletics and you sustained an injury during a rec sport, you're probably not going to have that data available. I think it is important to get it.
Sure.
And take, some girth measurements of the thigh and the calf before the surgery occurs, and then also take some strength measurements if pain allows for it.
Got it.
So if that joint is calmed down and they're able to use their muscles, there's no reason why you shouldn't take a strength measurement before the surgery.
Yeah, and I think what's important to understand is that, orthopedic surgery in general takes a big toll, right, on the body, and we're going to talk a little bit about arthrogenic muscle inhibition. I think the idea is that you want to make sure that before you have the surgery, you know where you're at. So then you have some benchmarks to kind of reach after the surgery, right?
Absolutely.
So let's get into it. It's a mouthful, right? Arthrogenic muscle inhibition. Does that start after the injury or after the surgery?
Yeah, so it's that big, long phrase, AMI for short, just means that something's going on in the joint that is inhibiting your muscle's ability to fire.
Sure.
And that can happen with an acute injury. That can happen after a surgery. Anytime somebody goes in under the knife and they touch a ligament, that's going to change your body's perception of that ligament.
Sure.
Because all of our ligaments have little sensors in them that tell your brain where that limb is in space.
Right.
And so, after a surgery and that joint is nice and swollen, if you still have that swelling present, that delays your ability to activate your thigh.
Yeah.
And what they've found with brain imaging when you are trying to activate your thigh after a surgery is that, in a sense, the lights are on in the brain to turn the quad on, but the lights are very dim. So you don't have access to everything to produce that force. And a big factor of that is because of the swelling that's in the joint.
Gotcha.
That's why it's so important pre-operatively and post-operatively to get the swelling down.
Okay.
Now, some kids will come in, they're like, I want to do more, I'm at week 6. My friend's at week 8 and he's doing this and this.
Yeah.
But you look at their joint and it's very swollen.
Sure.
We have to hold you back until this gets under control.
Until it's ready.
Because that's going to inhibit your ability to get stronger.
And that's the art, right? I think that's the art of it, right? I think one of the big things with PT is that a lot of people want, okay, at week 2, you're doing this. At week 6, you're doing that, right? And it has to be so precise. But the truth is that those are more general guidelines, and you got to play within where things are at.
That's
Would
true.
you agree?
That's true. And the rehab community is going more towards a criterion-based rehab approach rather than a timeline-based approach.
Good
I
call.
think why the timeline-based approach, like at X amount of weeks you're going to be able to do this, why that was instilled early on is because we're following tissue healing timelines.
Sure.
So we know, at 12 weeks, this is going to be healed. At 16 weeks, this is going to be healed. But that doesn't tell you about the rest of the body.
Right.
That tells you about the biology that's happening underneath.
Sure.
But the entire nervous system, the entire person is affected by this injury.
Now, obviously, most of these guys or gals that you see are younger. They're typically fit. They're typically athletes. So, they're in decent shape. But even at a young age, are there any nutritional recommendations before surgery? Any supplements that you've seen being used, or is it more like, well, the majority of the time they're young and healthy, they just have the surgery, we'll see you after?
Yeah, I think super hot topic right now in the rehab world, just paying more attention to this.
Yeah.
Because I don't know about you, but when I've had surgeries in the past, the last thing I want to do is eat.
Yes. Yeah.
Because I know that I'm not physically active.
Sure.
And I'm just kind of like wasting away.
Yeah.
And so I don't have that same kind of drive to eat.
Yeah.
And probably what I'm eating is going to differ if I'm training 4 hours a day versus training 0 hours a day.
Sure.
So I think that protein intake is critical right after a surgery because you are trying to build muscle.
Yeah.
And we all know that in order to build muscle, your body needs protein to do that. And so I think a lot of people fall off and stop eating quite as much after a surgery, and then that contributes to the atrophy response that they get.
Yeah. Agreed.
Now, in terms of supplements, there are a couple of things out there that have shown some promising results on a few studies. So if, let's say, somebody has a patella tendon graft, that is a tendon that they're taking, right?
Yep.
And becoming a ligament that they are now using as their ACL.
Sure.
But that graft site, for a long period of time, can have some pain to it because it is regenerating. There's still a lot of disruption in the fibers. We get a lot of that transition of type 1, type 3 collagen.
Yeah.
And you can supplement with things like collagen and vitamin C together to try to help stimulate the growth of those tendon cells in that area.
Yeah, I agree. Collagen, I think, is a really good option there. Vitamin C is an interesting one, right? Because I think you need it for healing, but also it may have like an anti-inflammatory effect as well.
Right.
One of the things I think most people don't know how to eat, right?
Yep.
And I think when I look back at my diet when I was an athlete, I think I just got away with it because of how active I was, right? But looking back, one of the big things you could do is just count the macros.
Yep.
And I think that's the way to learn how to eat, right? Where you can, look at exactly what kind of protein, fat, carbohydrate, and sugar composition of each food that you eat. And it's a pain to have to weigh all the different structures, but I think that's the way that you learn how to eat. And to your point, if I'm going to have a major surgery, I want to have a baseline, kind of what I eat, and then probably going to increase my protein up, right? Maybe immediately after the surgery, you're probably going to get a little more carbs in, right, to try to kind of fuel the regenerative process. But you just want to have control, right? And what I've always thought is typically a gram of protein for every pound that is your ideal weight.
Yep.
Is that kind of a good, little tip we can give?
I think that's part of the low-hanging fruit. The other part is that shopping on the periphery of a store instead of in the middle in the aisles.
Yes.
Where there's a lot of packaging. On the outside, you've got your meats and your veggies, right?
Yeah.
But anything more specific for a deep dive, you go try to work with a sports nutritionist to talk about these things. Yeah,
the quality of the food, right? Unfortunately, the food we maybe ate when we were kids doesn't exist anymore, right? It's a lot more processed than even, we can get into that whole topic. But the point being, pay attention to know what you're going to eat. And as soon as you have the injury, and you should be doing it anyways if you're an athlete, but if you have the injury, make sure you set your body, you optimize your body for success after the surgery.
Right.
All right, let's keep going here. Anything else you want to say about prehab? I think that's pretty good. Okay, so you've had the surgery, right? Let's call it day 0. How soon should someone come to physical therapy after the surgery, and kind of guide us through that acute phase, if you will?
Yeah, that's all dependent on the surgeon's preference. So surgeons that we work closely with are sending us people within the first 3 to 5 days post-surgery.
Yeah.
And then sometimes surgeons' preference is to wait a week, and that's fine. But when we see somebody 3 to 5 days post-surgery, we are really able to get ahead of the game. It doesn't mean, hey, I'm going to see somebody 3 to 5 days post-op and then that's going to knock off 2 months in their return to play in the end.
Right.
That's not true.
Sure.
But we might be able to get them more comfortable in the early
Sure.
stages
Sure.
because we can teach them techniques to reduce the inflammation,
Yeah.
to get their quad going a little bit. We can use some modalities to get their quad going.
Yeah.
So usually within that first week, we're trying to get somebody in to see a physical
Sure.
therapist.
Now, in the topic of post-op swelling, ice has been kind of controversial.
Yeah.
What are your thoughts on ice? What are your thoughts on compression?
Yep.
Right? Like, what are your strategies to bring the swelling down?
We definitely use both in the early
okay.
stage. So ice, for whatever reason, got a bad rep recently.
Yeah.
I think it's necessary for some things,
Sure.
especially post-operatively,
Yeah.
and especially when there's pain involved,
Sure.
and then unnecessary for other things.
Yeah.
So I think for a post-op ACL, ice is super important.
Yeah.
I think a compression sleeve is very valuable as
Yeah.
well, because again, if that swelling is present, that's going to inhibit your ability to
Yeah.
use your muscles. So we're trying to get people on that, within the first 24 hours.
Sure.
Get them a sleeve, get them some ice.
And a floss band, what are your thoughts on that?
So at our clinic, we don't use them as much because we have access to compression sleeves and
Gotcha.
ice. So I just have less experience with that,
Yeah,
and
sure.
yeah, can't speak on it.
No worries. I would also say that having my own surgeries, especially right after, nothing feels better than ice.
Man,
It's
yeah.
just like, finally, you know what I mean? Some at least, couple of hours of relief.
And just to tie it back
Yeah.
into the AMI, the Arthrogenic muscle inhibition, one of the things that people have found, and this is going back decades of research,
Yeah.
to be able to access your quad is icing before the session starts.
Interesting.
So
yeah.
preoperative cooling can
Yeah.
get those nerves that are sending a message to your brain, hey, something's wrong in my joint.
Yeah.
If you cool the area, that can disrupt that message.
Sure.
So you don't have as much of that information coming to your brain saying, hey, something's wrong,
Yeah.
so that it limits your quad. Now with that pre-session ice, you can access your quad a little bit more.
That's interesting. It sounds counterintuitive,
Yep.
right? But I can see how by kind of shutting down the fire or the pain signal,
Yep.
it allows you to do a little bit more.
Exactly.
All right, so early on, it's really about, like you said, swelling control, early range of motion.
Mm-hmm.
What are your thoughts, and does it matter early or this doesn't matter as later? I think the patellar tendon graft is still probably the gold standard.
Right.
Obviously, some really good work with hamstring grafts, also quad tendon grafts.
Right.
Does that change the early phases at all, or does that come later?
It definitely changes the early phases because people most often have some donor site pain.
Sure.
They have some pain that is coming from the site that they took the graft from. So you have to address that as a therapist.
Mm-hmm.
So that might mean that I am programming my early phase to do some tendon health work
Gotcha.
for that graft site. If it's a patella tendon, we're doing some long hold isometrics to try to generate some turnover in those cells in that tendon.
Gotcha. Early on.
Early on.
Okay.
Yep. So
it does matter.
it does matter. We're changing based on the graft. Yep.
Yeah, and I think, if you're a patient looking at these are questions you want to ask your surgeon, right? Is what graft do you use? Why do you use it? I don't know that there's necessarily a right or wrong, but you just want to go to a surgeon that has a lot of experience using that specific graft.
Right.
I would also say if you're younger and you're going to return to a very high impact sport, maybe an allograft is not the best option. And maybe if you're older and you want to avoid some of that post-graft pain, you can use an allograft. But again, these are all things that you have to take into context and really discuss with the surgeon that you're going to do it with.
Right, and also matters what they're getting back to. So
Right.
if this is somebody that works on their hands and knees, or they play a sport like wrestling that requires them to get down on their
Yeah.
knees often, or that is going to be a lot of pressure on a patella tendon graft.
Yeah.
That might not feel as good getting back to your sport.
Sure.
Versus a hamstring graft. If you're a 100-meter sprinter, taking a hamstring graft with the demands on the hamstrings during a top-end sprint,
Yeah.
maybe we do a patella tendon graft instead there.
Sure.
And that's a discussion for the surgeon and the patient.
Yeah.
But I think you said it right. Like whatever that surgeon is best at doing,
Yeah.
use that graft.
Use that graft, and then also try to advocate for yourself, like, hey, these are the things I want to get back to. How does that graft fit in?
Yep.
Because what I have seen in the past is, more so maybe with allografts, a young person gets an allograft, they return to football, they re-tear, and then they go read, and they're like, oh, now, why did I get an allograft? There's a higher chance of re-tear, and so try to understand, what you're getting into, and unfortunately, you have to advocate for yourself, right?
Right, right.
Or fortunately, right? Because it means you have options. All right, so we're still staying early phase. Can you explain the role of neuromuscular electrical stimulation, which is also known as NEMS, and how you use it in practice?
Yeah, so what it basically looks like is a couple electrodes on your thigh, and you are using those electrodes to help stimulate your thigh muscle. Because as we talked about, your ability to turn the lights on, it just isn't as good for your thigh muscle after a surgery.
Yeah.
So we are using electrical stimulation to do that for you, in conjunction with you actually doing some work for your quads on your own.
Sure.
I think that people were, less apt to use this earlier because it's hard kind of from the sense of a PT. Like I have to know the parameters to set on this device.
Sure.
It takes a while to set up. Is it really worth it?
Yeah.
But research study after research study shows that that can help reduce the atrophy response.
Yeah.
So we use it with, most of our ACL patients right
Nice.
afterwards. And the way we dose it is all based on Delaware University.
Yeah.
They have a great ACL research lab, and they put out some guidelines for therapists. We use exactly the parameters that they use.
Sure.
And it seems to be extremely effective.
Yeah, what was that article called? Who's Afraid of Electrical Stimulation, right? That was a good
Right.
review.
And that was to us as
Yeah.
physical therapists. Like, we need to use this
Sure.
modality more, and we have been afraid to use it in the past just because we're not comfortable setting it up. We're
Right.
not comfortable pushing people intensely early
Sure,
on.
sure.
But there are ranges of motion, and there are areas that you can safely push somebody
Right.
with the help of NMES.
Yeah. So just so you guys know, if you just scroll down below, the links to some of these articles are going to be there for you to access and read. So, feel free to access those. That way you can actually get a little bit deeper into each one of these sections. So the next big one, I think, is blood flow restriction, BFR, a good early and even maybe later tool. I think that's something that's blown up over the last few years.
Yep.
How have you incorporated it into ACL rehab, and how do you see it kind of moving forward?
Yeah, we especially love it in the early stage. BFR is basically just kind of like you would get blood pressure taken at the doctor. It's the same thing, but it goes on your leg, and it is reducing the blood flow to your lower body while you're doing a workout.
Yeah.
So the reason why it's so useful early on is because in those first few months, we can't lift heavy weights.
Right.
If we can't lift heavy weights or move fast, that means we can't access all of our muscle fibers.
Right.
It's those type 2 muscle fibers, the big ones, that really change in size when
Sure.
we get stronger. And if we can't do heavy things or fast things, we're not going to talk to those muscle fibers. Therefore, we're going to get some atrophy. But with the use of BFR, what you can do is work really hard because you've limited the blood flow.
Sure.
Now your body has no choice but to access everything.
Gotcha.
And then you can get some hypertrophy, some muscle growth as a result by utilizing the BFR
At a much lower load.
at a much lower load.
So it's like your body, so basically what it is, if you don't know, it's essentially almost like a blood pressure cuff.
Yep.
That you can calibrate and, squeeze down, in whatever body part, arm, leg, and it basically occludes how much blood can go through, thus blood flow restriction. So again, you can do a very low resistance exercise, almost just like an isometric hold, but the muscle itself feels a much stronger load than what you're giving it in
That's right.
actuality.
And there are also some systemic benefits to it
Yeah.
as well. So hormonally, you get a change that can increase your ability to upregulate protein synthesis.
Yeah.
And that happens just by using the cuff.
Sure.
So there are actually some studies of the cuff just being on
Yeah.
and you actively not doing as much,
Sure.
and that being able to mitigate atrophy.
Yeah. Let's talk about the psychology a little bit, right? Because, these are big injuries. They
Huge, yep.
typically always come at the wrong time.
Yep.
And they can be devastating as an athlete to sustain that. When do you see kind of the biggest hit, right? Is it immediately after the injury? Is it after the surgery, right? When you're down in the dumps? And, what do you strategize in terms of, okay, how do I help this person, like, keep their mood up, keep them stimulated in rehab? Like, how do you work through some of that?
Yeah, I think it comes in waves for sure.
Yeah.
Right after the injury, definitely things have changed. Your outlook on your future has changed.
Yeah.
You have that discussion with an orthopedic surgeon. They tell you it's going to be a year.
Yeah.
That's tough to swallow. You're going to be taken away from the sport you love for a full
Sure.
year. And then in the first 3 months, you're really not able to do a ton.
Yeah.
And that's another wave that hits you.
Sure.
Later on, after 4 months to 10 months, you're feeling pretty good.
Yeah.
You're doing a lot of things that look like your sport,
Sure.
but there's then that last wave of where you're feeling great, but you might not have been able to test out of, your return to sport test. And so you're still not able to play your sport, but you feel like you can.
Gotcha.
And that's the part where it's really unsafe to go back.
Sure.
But you feel like you can.
Yeah.
And so psychologically that plays with you a little bit.
Got it.
Because it's hard not to be on the court or on the field.
Sure.
When you personally feel like you should be out there.
You should be out there. Got it. All right, we're going to close out the early phase with, what are the common mistakes you see people make early on, right?
Yep.
What are some of the pearls in terms of like, hey, don't do these 3 things in the first 3 months?
Yeah. I think bigger mistakes are that people do too much too soon.
Yeah.
They see on Instagram that some dude is squatting half reps with 225 a couple months out, and they're like, shoot, I should be able to do that because I'm really strong too.
Yeah.
But they have a swollen knee, and so all that load is going somewhere else.
Yeah.
So doing too much too soon, not achieving full knee extension.
Yeah.
We know that is critical.
Sure.
You have to get your full knee straightening ability, your ability to completely straighten that leg compared to the other side.
Yeah.
Even if you have hyperextension, you need to get that range of motion back.
Sure.
So I think that full knee extension not happening in the first month is a mistake that we see often. And then just not taking, the rehab part seriously where you need to exercise your thigh.
Right.
It feels like you're not doing much,
Yeah.
but you are preventing so much muscle wasting by doing some very basic exercises.
I think what's tough is, the ACL tear itself, obviously in the moment is painful, but I see a lot of people that within a few weeks, they feel a lot better. They're almost like, oh, like, is it really torn? Like, it doesn't hurt.
Right.
And then you have the surgery, and it's like a truck ran you over, right? It's like you're so much worse, right?
Yep.
And I think it's just being prepared for that. And one of the things is mindset, right? And it's easy to just fall and just say, oh, man. But I think it's just, a little better every day, a little better every week. Just keep kind of just thinking, in a year I'll be there, and just focus on the effort, right? On getting the quad sets in, which becomes so repetitive and boring. And again, you're used to running, running, cutting, pushing people over, dunking, doing all these things, and now you can barely walk, right? So it's just, you just got to get through that, and the body's awesome at healing, right? So most people, will get there. All right, so that's early phase. Let's talk a little bit about the progression. Obviously, we'll get to return to play.
Yep.
We just talked about, what would you say, month, 0 to 3, would you say that? So now what is going to be 3 months, 4 months to like maybe 7 to 10 months? Is that kind of that middle?
Yeah. So I think that early phase, you are basically trying to grow your muscles back.
Yeah.
You're trying to get your full range of motion, then you're trying to get your thigh girth back. That means like your muscle is actually there.
Yeah.
We get kind of stuck in this phase of making sure that the muscle comes back.
Yeah.
And then pushing people too quickly with fast movement often.
Sure.
So we tend to test people in that 12 to 16 week area where we're actually setting them up in a fixed angle, and we are seeing how much power can that muscle produce compared to the other side.
Yeah.
And that's going to give us an idea of how comfortable is this person producing force.
Sure.
How well are they kind of prepared to run and jump?
Yeah.
And we use that as our guideline to determine their progressions. If we just go week 16, boom, you can start to run, that's not okay. We need to know if they are capable of sustaining those loads.
Sure.
Because if you're running, 1 mile and you're running at 160 steps per minute, that's 80 foot contacts per side.
Right.
And then you multiply that by how many minutes, that's hundreds of foot contacts.
Sure.
If you go through your rehab and all you're doing is squats, split squats, single leg RDLs, hamstring curl, and then all of a sudden you're running, that is a huge force differential there.
Sure.
So we have to make sure at each phase, starting at the 3 to 4 month mark, that athlete is prepared to withstand the loads of the next phase.
Sure.
So we're always using strength as a guide to progress us.
I think the dangers of this middle zone is you're out of the woods, right? Like that acute phase, you're back to normal day-to-day activities. The pain is probably a lot better. You can kind of get around and do a lot of the stuff you were doing aside from athletics, right? And I think this is the time point where not all athletes or all people, but you get complacent, right? And you start to pull back, right? You start to take your foot off the gas. And I think You don't want to overdo it, but this is actually the most critical time, right? So you can get to return to play.
Right.
Is you got to keep that foot pedal down. You got to keep, focusing on the nutrition, focusing on the strength, right? And making sure that you don't just say, oh, I'm good,
Yep.
right?
Yep.
I think that's kind of the dangers of this middle ground. And also maybe the opposite, right? Where you do too much, right? You're feeling good and it's like, oh yeah, I went on a trip. You go on a trip. Typically that's what does it. A trip with your buddies is probably
Playing spike ball on the beach
yeah,
at month
exactly.
2.
Yeah, those are going to be the things that get you.
But really in that phase where programming perspective, we're looking
Yeah.
at changing from like sets of 12 to 15
Yeah.
to now sets of 6 to 8, because now that their muscle bulk is back, we're trying to work on strength. We're trying to get that symmetry back up so that they can withstand the loads of running.
Now, is this a time, so like for instance, UCL injuries, a big thing, whether you have biologics or you have a surgical intervention is, well, what caused the UCL tear, right? And it's typically pitching or throwing mechanics.
Yep.
Is this the time to look at ACL-wise? What led to you? I mean, it could just have been a traumatic thing, right, or a weird kind of. But are there patterns or are there things that you look for in saying, okay, what caused the ACL injury, and is this the time to address them?
Yeah, I definitely, we're having those conversations with the person on day one.
Yeah.
Was this a contact injury? Was it a non-contact injury? Is there some biomechanical difference side to side or an injury history on the same side that may have predisposed you to this knee injury?
Sure.
A lot of the times what we see is on the affected knee, that ankle has had an ankle sprain history and they are lacking significant dorsiflexion motion or toes towards your nose motion.
Interesting.
And that lack of ankle mobility means that there's going to be stress placed somewhere else.
Gotcha.
That's not always, by any means, but we do see that sometimes.
Patterns.
Another thing to keep in mind is, does this person have a connective tissue disorder?
Right.
Are they just ligamentously lax?
Yeah.
So maybe we're spending a lot more time on strength in those early phases than pushing them early for jumping. So we're looking at those, and then the demands of the sport.
Yeah.
So is this a contact sport where they're a high school or college running back and they're going to be getting hit from all angles all the time?
Yeah.
So we need to know how to prepare them for that.
Sure.
And we have to be really dialed on how we progress their cutting and their contact in the later phases. So I think, that mid stage, yes, it's important to know how it happened and address any really outstanding biomechanical patterns there are, but you're thinking about that from day one.
Day one. Now, what about, let me give you a couple of different patients, right? There's the, very young, 14 to 17. Then you have like the late high school or college athlete, obviously the professionals. But then what about the older, let's call it the 35 to 50-year-old that's still very active? How are you going to approach that a little bit different, or is it pretty much through the map, you're kind of flowing through the same flow?
Yeah, I think that those folks, a lot of them have families.
Yeah.
A lot of them have less time to dedicate to their rehab program.
Right. Yeah.
Things are going to be really simple.
Sure.
Giving them a program that they can do and get it done with all of the demands that the rest of their life has on them.
Yeah, they got to work, right?
They're working. They've got kids when they get home. They're getting up early. They have maybe 30 to 40 minutes to put into an exercise program 3 times a week.
Yeah.
So we just have to be really on top of our programming for those people. And I think that that's really important, because oftentimes it's those people that are just super dialed on their programming because they know that they only have so much time to get it in, and they're going to do it.
Sure.
Because if they don't, they know and feel their weakness in that knee.
Got it. What about in terms of contralateral, like how real is the risk of, if you tore one ACL, I've seen a lot of tears on the other side.
Yep.
How do you combat that, and when do you combat that?
Yeah, I think that that is a difficult issue, and it's a little bit foggy because many people that pass return to sport testing criteria do not get a re-injury on either side.
Sure.
But those folks that don't pass return to sport injury, they're about 40%, 30 to 40% of those people actually sustain an injury on the same side or the opposite side.
Which is a high rate.
It's very, very high, and I think that most of the reasoning for that is that they are weak when they get back to their demands of the sport. And because they didn't pass those criteria of having at least 90% quad strength and hamstring strength on
Yeah.
that side, their body's just not prepared for the cutting.
Got it.
And maybe they're prepared for 5 to 10 cuts,
Sure.
but if they're decelerating a couple hundred times in a soccer match,
Yeah.
it's not going to hold up.
Hold up. Yeah. All right. Well, I think it's a good transition to return to play, right? So we've gone, we've gotten our muscle strength back, range of motion's good. I'm not having swelling or pain. All right. I'm ready to kind of go through my return to play program. We can focus on football or generalities. How would you kind of get someone moving in that direction?
Yeah, so at Mac Performance, we have a return to sport class. It's an ACL I'm Back class, and currently we have 10 to 20 members in that class.
Nice.
They're all getting back to sports of different kinds, whether it's recreational pickleball, tennis, or collegiate soccer or football.
Sure.
But we have that available at both of our locations.
Yeah.
And the architect behind a lot of our return to sport programming is Chris Fries.
Yeah.
He's a physical therapist on site with us here, and then Bailey Iwasa in Folsom.
Yeah.
And they've really dialed in how to safely progress people from a deceleration standpoint, from an acceleration standpoint, from a talking to the coach and saying this person is cleared for 15 minutes of practice non-contact this week.
Yeah.
We're going to bump that up to 40 to 50% in the following week, and having a graded progression.
Sure.
I think a lot of people make the mistake of they get their strength up, but then they don't prepare themselves for how many decelerations happen in actual practice.
Sure. Yeah.
So if you're a midfielder in soccer,
Yeah.
you're going to have several hundred decelerations,
Yeah.
meaning you are slowing your body down to change direction.
Got it.
And if you are a high school or collegiate wide receiver, you're going to have around 100 of those.
Sure.
50 to 100 at very high speeds.
Yeah.
And so if you get 90% quad strength, but you don't work on a graded progression to get back to your sport, it's going to be difficult for that knee or the other side to hold up.
Yeah.
And
Understood.
what we do is a 4-phase program,
Okay.
where in each phase we are focusing on a different thing, and we have criteria to pass each phase.
Yeah.
And this is guided by a physical therapist and Nick, our performance coach.
Okay.
And so what that looks like is a bunch of athletes are in there, maybe 10 to 12 athletes. There's a couple of coaches working with them, and some people are working on phase 1, which looks like basic straight line, accelerate, decelerate.
Yeah.
Some people are working in phase 2, and they're trying to work on their more top end acceleration stuff and a little bit of lateral movements. Phase 3 is more like cutting, starting at lower angles and then finishing at steeper angles.
Sure.
And then the last phase, we're looking at reactive cutting and sport specific and contact and those things. And we have criteria at each one of those phases to make sure that that athlete is safe to progress.
So it sounds like a lot of it is not so much managing the specific movement, but managing the repetitions or the load of the movement.
Yep.
Is that accurate?
It's definitely
Okay.
accurate. And what we do at each phase is we do a slow motion analysis of somebody's deceleration. They're running in a straight line, they come to a stop, and we can have eyes on, hey, maybe this person has 90% quad strength, but they are offloading that side a ton on the sprint to deceleration. So I know that other side is getting 150 to 200% of the load.
Sure.
So we need to work on some drills where they're actually using this side and figure out why are they not using this side.
Got it.
And another way that we can look at that is using force plates for jumping.
Okay.
We do a double leg and a single leg jump on the force plates, and we're looking at the slowing down component of that, or the eccentric component, the takeoff component, and how quickly they can go in between those two.
Sure.
And that gives us some insight into maybe this is why when they're slowing down, their limb is not translating forward as much.
Okay.
Maybe they're really good at slowing down, but they can't speed up.
Got it.
And so we're utilizing our technology to inform what we're doing in our ACL class.
Now, and is that as a comparison to baseline, or is that more at the time comparing side to side with the force plates?
Side to side.
Side to side.
Yep.
Okay, so you want to see symmetry.
We want to see symmetry.
Okay.
And we have some numbers that are available through the company that we use is Vald for force plates and for a force gauge. We have a lot of data available that can tell us what the norms are for a high school soccer player, for a collegiate soccer player, and we're also getting an idea of, okay, where does this person stack up to those?
Now, I think one of the biggest questions always, from parents and the athlete is, well, how long, right?
Yep.
We saw some progressions where at the beginning it was like typically a year. Then, the big case subject was Adrian Peterson. I think he came back at 6 months.
I think he was in a game at 8 months, but
At
he
8
did
months.
come back to practice much earlier.
Right.
I think maybe 6 months.
Which is, crazy. And obviously,
insane.
Freak athlete, just an amazing specimen. How do you counsel, for instance, like I was a soccer player, I don't have Adrian Peterson's body, right? Or you see a LeBron James, right? I don't have LeBron James, right? So how do we talk to athletes and parents, especially with the younger ones, as to, hey, this is going to be a year, there's no need to rush back, also understanding the biologic of what you said, right? You're basically asking a tendon to become a ligament, right? So it has to perform a different function. It has to mature and harden, and you have to give it time, right? So how do we talk to patients about what the true return to play expectation is and how not to push too fast or too slow?
Yeah, I think that starts on day one with the parents and the athlete if the parents come to that visit with them and it is a high school athlete, because we kind of just set the expectation that this is going to take a year.
Yeah.
If it takes shorter than that, that's awesome.
Sure.
You crushed it.
Yeah.
Nice job. But let's get it in our minds that this is about a year-long process.
Yeah.
We've found over and over again in studies that if you come back, let's say at 7 months versus 8 months, your chance of re-injury at 8 months is 50% less than it was at 7 months.
That's
if
a
you
lot,
delay again to 9 months,
Yeah.
it's another 50% less.
Yeah.
So up to 9 months, there's a 50% reduction each month
In re-tear.
in re-tear rates.
Yeah.
So getting that stat to parents is really important.
Sure.
And then in that 9 to 12 month mark, that's when a lot of collegiate athletes are getting back to at least practice.
Yeah.
And then they're maybe taking a 4 to 6 week accumulation phase where they're getting the demands of their sport down. And then maybe at that closer to 10 to 12 months, they're playing in a game.
Sure.
But we're always talking to people as if this is going to take a year. Just set that expectation. If you get back before that, that's awesome.
Now, the year, it's a really good time point, but I've also heard from athletes that at a year I was playing, I was back to sport, but I didn't feel like it was my knee again till like year 2.
Yeah.
Right. So what have you seen in terms of like, okay, how ready, I mean, and I know it varies a lot, but what is the true expectation at year 1 versus year 2?
Yeah. I think that a big part of return to sport is knowing if the athlete is ready.
Yeah.
If they say they're not ready, they're not ready. Even if they pass every single test.
Yeah.
If they don't pass the questionnaire, which is like an IKDC, if they don't pass that questionnaire and their confidence level is low in their knee, we're not clearing them.
Yeah.
Because that is a huge component.
Sure.
They have to pass the eye test and they have to pass their own test of themselves being ready. Now, if they say I'm ready at 6 months and they don't pass their test, that doesn't work that
matter.
way. But I think the mental side of things is really important. We found that if somebody is very strong and they've done a graded return to sport progression, they're confident in their knee.
Yeah, they're doing good.
If somebody is not quite as strong and they've kind of skipped around the phases a little bit, they're not going to be ready, just psychologically.
And obviously you can return to play, right? And man, it's miraculous what we've been able to do with surgery, science, and rehab and getting these athletes back. But how are they the same? Are they back to their pre-injury levels for the most part? Do they lose explosiveness? Is it more of a mental thing? Like, how back are you?
Yeah, I think that totally depends on the age and the demands of their sport.
Sure.
So if you're a NFL running back and you sustain an ACL injury and then you get the surgery and you come back 1 year later, you do have a performance dip.
Yeah.
That's been shown over and over again.
Sure.
There's a performance dip there, but people have long careers afterwards.
Yes, they do.
So it's definitely possible to tear an ACL in high school and then have a long NFL career.
Sure.
Same thing goes for soccer.
Yeah.
But again, you got to look at the demands of the sport, the demands of the position in that sport, and kind of what else was going on. Some of those non-modifiable risk factors, right?
Yeah.
Are there other things that may have contributed to this ACL tear that may contribute to another injury? You have to keep those in mind as well. People do get back, they do get to their full top end speed, but a lot of the times we do see a performance dip.
Sure.
Whether that is due to a strength deficit, maybe they're at 90% instead of 100%,
Right.
or maybe it's due to a quickness and muscle timing thing. Not really sure. You have to delineate that out with case specific examples.
Sure.
But on the whole, there seems to be a performance dip, but not a dip in their peak velocity in their testing metrics.
Okay.
But if somebody gets back to 100% symmetry, they're usually looking pretty darn good.
Long term, I think for the most part, it's a pretty successful surgery. Obviously, there's complications with any surgery and any big injuries, which we could probably have a whole side talk on.
Sure.
But I think for the most part, it tends to be a pretty successful surgery. What do you tell them long term? Obviously, we've seen a subset of patients get post-traumatic arthritis, 5 to 10 years later.
Yep.
Are there certain things that you want to talk to people about or try to prevent in that regard?
Yeah, if you look at the population that hasn't sustained an ACL injury,
Yeah.
one of the largest predictors of knee osteoarthritis is quad weakness.
Okay.
So if just in the healthy population, if quad weakness is a risk factor,
Sure.
you know that if you're getting back to something after a surgery, you're going to have quad weakness.
Yeah.
You have to do everything you can to mitigate
Keep
that.
going. Yeah.
So your rehab does not stop at 12 months.
Right.
You're continuing to progress your single leg strengthening as much as you can.
Sure.
Because you want to keep that quad strong for life,
Yeah.
and that's going to help prevent some of those
Sure.
things like OA from developing.
Okay. Now, you, I think, mentioned to me that sometimes the calf is kind of like the forgotten stepchild.
Yes.
Tell us a little bit about, your initiative, because you said that's on us,
Yep,
right?
that's totally on us.
We focus a lot on the quad, and rightfully so, but what about tib and calf and gastroc? What do we have to do there?
Yeah, so oftentimes, I think in rehab, it's the quad until it's not the quad for ACL specifically.
That's a good way, yeah.
The quad is almost all the time the problem.
Yeah.
But if you are taking, symmetry measurements of somebody at 16 weeks, you take the measurement of their calf and it's 1.25 inches less than the other calf,
Sure.
we've done something wrong.
Gotcha.
We haven't pushed them enough on single leg calf work
Yeah.
in order to get that muscle volume back like we did with the quad.
The quad.
So in the past, I think I was, guilty of doing this in my first couple of years of practice, is just making I did not make sure that I was getting people single leg calf raises 2 to 3 times a week with a high volume in order to get that calf back quickly.
Sure.
Because if you don't do that in the first 12 weeks, it's going to be really hard to get that back. And it's probably not going to come back until, closer to 9 to 12 months.
Wow.
So you have to exercise the calf just like you do the quad.
Sure. You got to push it.
Yep.
All right. So we're getting near the end here. If you could give one piece of advice to an athlete that just had an ACL tear, what would it be?
I think it sucks. You didn't deserve that to happen to you, but it's done. You're going to address it, and this next year you're probably going to go through something that's harder than anything else you've done in your life.
Sure.
And you're going to realize a lot of strengths about yourself through different ways of pushing yourself through things. It's something that you're going to think about every single day until you're back to your sport.
Yeah.
And what we always say to athletes, and this is what my physical therapist said to me after my shoulder surgery, was that you have a specific advantage right now to understand your sport through a different lens than when you were playing. Now you can pay a little bit more attention to your film, to what the coaches are saying, to what it looks like from the outside looking in at the sport, and develop a strategic advantage of the mental side of sports.
Yeah.
And that's going to help you become an even better athlete when you get back to your sport.
Dude, that's awesome. Yeah. All right, we're going to finish out with a rapid fire here, a little lightning round.
Let's do it.
All right. Tougher athlete to rehab, a soccer player or a football player?
Depends on the position. I think football running back is very tough because the amount of contacts and the amount of cuts that happen. But soccer midfielder, they're running forever. So it depends on the position.
I will say, man, the locker rooms are so different.
They're way different.
Like being around, more as a physician in different team atmospheres. Like the baseball locker room is just like fun and joke and pranks, right? Football obviously is intense, especially game day.
Yep.
Soccer is kind of like an intermediate thing. Man, every athlete is different. All right, we're gonna keep going. Favorite quad activation exercise?
Late phase, I'm going rear foot elevated, safety bar, split squat, eccentrics.
Woo! You're gonna have to show us that one.
Early phase, probably split squat pulses with BFR and NMES at the same time.
Try doing that one. All right, most overrated recovery tool.
Most overrated. There's a lot of them.
A lot, right?
There's a lot of them. I don't even know. There's probably 10 of them.
All right, well then let's flip it. What's the most underrated recovery tool?
Sleep, for sure.
Yes.
7 to 9 hours of sleep will do so much more for you than any other recovery tool combined.
Yeah.
Sleep is the most underrated thing.
I think I know the answer to this, but compression sleeve, love them or leave them?
Love them, especially early stage. Late stage, not as necessary.
Not as necessary. If you weren't a PT, what would you be?
Lost without a purpose.
Playing a lot of fantasy football. All right, favorite pump-up song?
Desperado by Rihanna, or the guitar solo at the start of Money for Nothing by Dire Straits.
Ooh.
There we go.
All right, biggest rehab pet peeve?
Probably somebody saying, I can't.
There you go. You're like, dude, you're here to do.
Yep.
Yeah. All right, and then this one, I think, ice bath or hot tub?
Man, at this stage of my life, hot tub.
Hot tub.
I'm not going to put myself through an ice bath anymore. If you asked me 15 years ago, I'd say ice bath.
Ice bath.
Now it's definitely hot tub.
It sounds like the basketball is pumping up over there.
Yep.
All right, man. Well, thank you so much. I really appreciate you doing this. For everybody listening, I think there's some really invaluable tips here. Obviously, look down below. You can get Taylor's contact. You can find them at Mac PT, someone I've trusted with all my patients and even my personal stuff. So thank you so much for doing this.
Thanks
really
for having me, man.
appreciate you. And until next time.
Thank you, guys.